Hello, everyone. I am Susanna Looney. I am President-elect of ASAN, and thank you for attending our Fall Winter Webinar Series. And this is a special, we want to thank our sponsor. Our sponsor for the webinar platform today is Recovery Management Solutions. They are a third-party administrator that work with healthcare professional monitoring programs across the country. And we do want to see you, so please keep your cameras on. And please mute your microphone so as not to disturb the speaker. If anyone has any questions, please put them in the chat box or in the center of your screen. And this webinar has been approved for 1.0 Nursing CE through the California Board of Nursing. Certificate of completion with CE will be sent by email with verification that the survey has been completed. The survey link can be found on the ASAN webpage. And actually this happens pretty quickly, that once you fill out the survey, probably within 1 to 2 minutes, you'll have your survey emailed to you. Your evaluation certificate emailed to you. All sessions will be recorded in case someone has to leave, or if someone would like to view this later on, they'll be archived. A link will be sent by email when the recording is available. It usually takes about 2 days. And C is available for recorded sessions viewing once the survey is completed. Part of our fall, winter, summer webinars, we had the summer, part of our fall, winter webinar series is going to be Tuesday. It's monthly at 7 p.m. October 19th, Tuesday, will be Emotional Intelligence by Dr. Tracy Hicks. November 9th, 7 p.m. will be Publishing Basics by Dr. Mitchell and Dr. Christine Barakis. And on Tuesday, December 14th, will be Mindfulness by Dr. Mary Armstrong-Fouget. Please join us for those webinars also. Just a reminder, the webinars are free to ASAN members. Please spread the word. Most of our attendees said they are members, but please encourage your friends and colleagues to join. Any questions, certainly you can contact me or go to the website. And today's session is Methadone Maintenance, Why It's Still Viable. And this is presented by Irene Chodwell, our charter LPN, our first charter LPN. Irene has over 10 years working in the mental health and addiction field. She currently works in an SUD program in New York City and New York, and which offers both inpatient and outpatient treatment. She received a Bachelor of Science Health Services, Policy and Planning from New York University in May of 2001. And in 2011, Irene graduated from LaGuardia Community College as a licensed practical nurse and received her certificate as a practical nurse. Irene is a founder and president of the Black Nurse Consortium. And in 2019 to 2020, Irene served as New York State Director of the Association of LPNs. And also in 2016, Irene served for the National Council State Board of Nursing as a volunteer, as a course reviewer for the LPN exam. And in addition, in her free time, Irene is a volunteer at the Medical Reserve Corps in New York City, and she assists in times of external and medical disaster for public events that call for the need of medical assistance. Irene is the first, as I said, the first LPN to be a charter member. And lastly, and pretty impressively, Irene in 2016 was the 2016 LPN of the Year, nominated by the National Association of Licensed Practical Nurses. Irene, I'm going to stop sharing.
Okay, well, I'm honored to be here. So thank you. Thank you for the lovely introduction. So I'm a little jittery, so please bear with me. But without further ado, let's get this party started. That's my favorite line. So, okay, methadone maintenance, because I'm a behavioral health nurse, and why it's still viable. Objectives: explain the actions of methadone, describe methadone maintenance, discuss methadone maintenance therapy, appraise the effects of the COVID-19 pandemic on methadone treatments, and discuss the future of methadone maintenance and why it is still viable. If I'm going too fast, somebody please raise your hand or say something because, Okay, so what is methadone? That was one of my first questions when I started out as a new nurse at a OTP in Manhattan, right out of nursing school. I don't even think we covered it in mental health section when I was in school. And I literally had to go back to my drug book and look it up so I wouldn't be kind of dumbfounded as I was trying to take care of my patients. So some of the brand names for methadone, Dolafine, like in Latin, dolo is like dolor for pain, and phen or fen is like and. So Dolafine is one. Methadose, Intensol. I've only heard of Dolafine, Methadose, Methadone. And it comes in tablet or the disket or the 40 milligram, as they like to call it, the biscuit. 5 milligram tablet, 10 milligram tablet, and then the oral concentrate in the liquid form. It was developed in Germany during World War II as a pain reliever with the premise of having a less addictive properties than morphine. Methadone is a long-acting for opioid agonist, meaning it's a drug that activates certain receptors in the brain. So full agonist opioids such as methadone activate the opioid receptors in the brain, fully resulting in full opioid effect. It is a Schedule II controlled medication. I'm moving on to the next slide. And I'm moving on to methadone maintenance therapy. So that's where I'm currently at the OTP, where I'm working at in the Lower East Side. Methadone has been fully approved by the Federal Drug Administration in 1972 as a medication-assisted treatment. It can only be dispensed in the Substance and Mental Health Services Administration, or SAMHSA, OTP outpatient treatment program, and they were formerly known as MMTPs, Methadone Maintenance Treatment Program, which can dispense the treatment for opioid use disorder. It is used in conjunction with the following as a multi-pronged approach in a patient's recovery: cognitive behavioral therapy, CBT, motivational interviewing, MI, physical therapy, and for some, spirituality, and or NA or Narcotics Anonymous. Medication assisted treatment. So this is a new term to me. So I learned this a couple of years ago. So what they say, you learn something new every day. Medication assisted treatment is the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. It is also important to address other health conditions during the treatment. So some of our clients have co-occurring disorders when they come in. So it is important when we do the physical evaluation, especially for new admits. So we make sure that they are relatively healthy. We do the full physical with the EKG. We do the necessary blood work. We sit down and do the initial intake with the oral history to find out what other conditions they may have and what other medications they may take. Thus, the whole approach, a whole patient approach concerning the patient. Some of the medications that are used in the opioid dependency medications would be, it's a tongue twister for me, but buprenorphine. Yeah, I always get stuck on that. Methadone and naltrexone. I'm kind of fairly new in naltrexone, but I do remember the initial clinical research studies that were performed at the Columbia University Uptown. I remember they had actually advertisements on NYC Transit asking for people with opioid use disorders to come in and be a part of this research study. And upon completion, That's when technically Vivitrol, because naltrexone, the Vivitrol is the liquid or injectable form of the naltrexone. And I remember that being a part of a treatment approach that we used in a clinic in the Bronx for some people who would prefer to have it in a more outpatient setting and didn't have to come every day. But these medications are used to treat opioid use disorders, to short-acting opioids such as heroin, morphine, and codeine, as well as the semi-synthetic opioids like oxycodone and hydrocodone. These medications are safe to use for months, years, or even a lifetime. So for some of you who have worked in the past with these particular medications and or in the OTP, there are some people who have been in treatment, particularly with methadone, for decades. And there are some who are sporadic, meaning they relapse and or fall off the wagon. As some people are saying, get back on the wagon. There's nothing wrong with that because no one is perfect. And then there are others that are getting treatments while they're incarcerated. For example, here in New York City, at Rikers Island, they have the KEEP program. So they can get treatment while they're incarcerated. And then once they're released, they get transferred out to an OTP that's willing to take that particular client in. So now some of the drugs, sorry about that, yeah. Buprenorphine or Subutex suppresses and reduces cravings for opioids. It has a long half-life of 24 to 42 hours. It is broken down by the liver and excreted in the bile and the kidneys into the urine. For the combination product of Suboxone, which is buprenorphine and naloxone, it has a shorter elimination period with an elimination half-life from 2 to 12 hours. Now, with the buprenorphine and the Suboxone, most of the clients that we have and or I've had in the past that have been prescribed a particular medication, it was sublingual. They had to do the induction period when they first came in. They had to go through a full withdrawal. And then it was on a case-by-case basis to decide if they were the right candidate for that particular treatment at that particular time. I'll move on to the next slide. Excuse my throat, I'm sorry. Methadone, that's my favorite. Reduces opioid cravings and withdrawal and blunts or blocks the effects of opioids. The onset of the effects occurs 30 minutes after swallowing, and the peak effects are felt approximately 3 hours after swallowing. So the first half-life, the length of time which the effects are felt, is approximately 15 hours. However, with repeated dose and the half-life extends to approximately 24 hours. It can take between 3 to 10 days for the amount of the methadone in the patient's system to stabilize. So if we have a new client that comes in, or patient, I call them client, that comes into the program and they're actually new to methadone, they get the full physical evaluation by the medical staff. And it is decided by either the MD or the PA if the client meets the criteria for opioid use disorder, and they will have an initial prescription of 30 milligrams to start. At the clinic where I am, it's every 2 to 3 days that they're evaluated to see how well it is going and how they are increased by 10 milligrams. Usually, by the time they get to 100, it depends, everybody's tolerance level. They will do a whole different physical evaluation all over again just to see how well they are. And should it be increased again, we do increments anywhere from 1 to 10 because we have liquid, we don't have tablet. So then there are others who, based on their toxicology, because that is literally one of the best ways to tell how well a patient is doing with the methadone. We do have some people that have issues with that, but other than that, it is decided by what we call a clinical dosing and scheduling meeting, which is done every week. The client meets with their counselor and they discuss whether or not they should increase or decrease. Does the client actually want to start stepping down, coming off of the methadone? It is decided in that particular meeting what is the course of action to take, and then ultimately the decision is up to the medical director how we should go about. So to just give some people an idea how we work with the methadone at our clinic. And then naltrexone, at this particular clinic, we don't really use that too much, but I have worked at other clinics in the past where the provider has done the Vivitrol, the IM, and or the oral tablets. So naltrexone, the Vivitrol, the injectable, or Rivia, the tablet, is an opioid antagonist. So it blocks the euphoric and sedative effects of opioids and prevents the feelings of euphoria. Oral is 4 hours. I'm talking about the half-life. 6-beta naltrexone is 13 hours. The IM naltrexone and 6-beta naltrexone 5 to 10 days, depending upon erosion of the polymer. The Vivitrol is 30 days. They will come in, meet with the provider, discuss how things are going, also meet with their counselor. If it's time for the regular 30-day dosage, they get their injection. With the tablets, it depends on how well the client is, I would say compliant, but I know they do the word adherence now, how well they are about taking their everyday pill, because some people don't do well with taking the tablets every day. And I have seen in the past when they had issues with compliance as far as tablet form, they have eventually moved over to the IM, where the compliance was a lot better. All right, so I'm moving on to COVID-19 pandemic and methadone maintenance, because that was a big thing at the clinic. You do remember we went on pause or lockdown, however way you want to say it, as of March in 2020 of last year. With that being said, SAMHSA, which oversees all the OTPs, approved the following exceptions. That the states may request blanket exceptions for all stable patients in the OTP to receive 28 days of take-home doses of the patient's medication for the OUD. That the state may request up to 14 days of take-home medication for those patients who are less stable, but who the OTP believes can safely handle this level of take-home medication. I can tell you from last year, we did it by the following. If a person had a 6 times a week pickup schedule, they initially went from 6 times to every other day, Monday, Wednesday, and Friday. We were open 6 days a week. We were already closed on Sunday. So on Fridays, they got their pickup for the weekend. If they did well, they went to once a week. And then if they did well, they went to twice a week. For those clients that were already once a week before the pandemic started, we moved them to twice a month. For those clients that we felt had met the criteria who were stable, they received the 28-day take-home bottles. So the only issue we had was if somebody was either exposed to COVID-19 and therefore had to quarantine, or if they were diagnosed as positive. They were immediately placed in an isolation or quarantine type of environment, whether it be in a hotel. Unfortunately, if they lived in the shelter, they had to go to one of the shelter COVID hotels. If they lived with family, they had the option of going into a hotel, or if they lived in a house that was big enough where they could separate themselves, that's what they did. With that being said, we did drop-offs. So I'll explain that in the next slide. Again, the client or the patient must be medically ordered to isolate or quarantine. If the client or the patient had an approved uninfected family member or third-party designee to pick up the medication, they had to follow a necessary chain of protocols, which meant that, for example, if I was a patient and I had a family member who was not infected with COVID, we had to have the paperwork, including their ID. They had to fill out the form. The form has to be filled out by the medical director, who then has to submit it to the state, that in turn was submitted over to SAMHSA to say that, yes, this person meets the criteria and can actually come in and pick up the medication. That is your family member or third-party designee. If they did not have a family member or third-party designee either available, or if they were all infected, the state actually had a courier service by the New York City Department of Health. They actually had courier pickups. So they would have some of their same employees. We would submit the documentation. It was once a week. It had to be before 12 o'clock. It was the particular patient, why they were getting it, what was the proof as to why they needed a delivery. It was a drop-off service, and it was in lockbox. We were provided lockboxes by the City Department of Health. We had to label the boxes, and we actually filled the take-homes, whether it was twice a week, every day, once a week, twice a month, 28 days. The courier came, we did the necessary identifiers to make sure they had the right patient with the right medication. We had to make sure that the client was home before we even filled the medication, because if they were not home, they were not getting the medication. So we had to call them to remind them, yes, you're getting a delivery today. Yes, you have to have this necessary password. When the courier comes to your house, he's going to ask you what the password is. You have to give them the password. Then they're going to literally give you the medication. If the client was not home, nor if they did not have a designee that was allowed to even accept the medication, the couriers were not coming to do that particular patient that day. So technically, they would miss a dose. And if that happened, they would have to go to the emergency room to get a dose. And we would have to try it all over again the next day. So that was what we meant when we had our drop-off service, which technically ended earlier this month. But being that we started seeing spikes in COVID-19 cases again in New York State, we are only doing it now for those, again, who have been medically ordered to isolate or quarantine. And they have to meet that criteria, and the paper has to be submitted. So that's how we are doing that particular service. So that's some of the issues we've had with COVID-19 pandemic on methadone maintenance. Some of the other things we noticed, some of the patients that come into the clinic, it was a means of support, direct and indirectly. You met with your counselor, you met with some of your other friends, you bonded. Some of our clients did not have full access to the internet. Some of our clients didn't even have a phone. So when I move on to my next slide, I got it right? Okay. So I'll go back for one moment. We had large incidents of relapsing, because again, we had people at home with take-home bottles. They had no other type of services. Sometimes they couldn't speak to the counselor. Again, they didn't have a telephone, or they didn't have access to the internet to do like a telehealth or virtual call. And some of them end up going back from, say, once a week to every other day. And some of them relapsed to the point where we were like, you have to come in every day. We have to see you. You are of concern, and we need to keep an eye on you. So I would say with the advent of COVID-19, we've seen a lot of changes as far as telehealth and telemedicine. So I'll move to the next slide. With the advent of COVID-19 pandemic, medical practitioners and OTPs have had to rely on telehealth to deliver the care needed, including methadone. So these are the particular criteria for telehealth. which includes the use of the telephone set forth by SAMHSA as of March 2020. And might I add, as of August 2021, there were addendums to policies and procedures set forth in New York State by OASIS to reflect that. For existing methadone patients, for example, can they be allowed to receive their services? Yes, they could. For the new methadone patients, no, they will actually have to come in person in order to do, say, for example, if they were being admitted into the clinic, the physical evaluation and the initial dose and the titration procedures. As far as counseling, again, before the pandemic, we had various groups where the clients were able to meet up with their counselors or whichever counselor was leading that particular group for that particular day or time. So it was a loss of camaraderie, the loss of belonging, and trying to adhere to a individual session via virtual media. Sometimes it did not work well, but it was allowed. Again, we had issues with toxicologies as far as, since nobody's coming to the clinic, how can we have that done? So sometimes if we had the consent between our provider at the clinic and the patient's provider, we were asked, and when you're doing the blood work, this is what type of blood work we would like for you to do. Sometimes providers agreed, sometimes they didn't. Or others, we would literally have to wait until the client, it was their time to come to the clinic, and then we were able to collect the necessary samples we needed. Also, the education of patients, providers, and public are the benefits of methadone maintenance as it pertains to the COVID pandemic, because it obviously, as you guys know, there is a great stigma associated with methadone, people who take methadone, and methadone programs in general. So that was a great hurdle to try to get over, to not only for our patients, for their family members, but most importantly for their other providers, maybe for their psychiatric provider, maybe for their medical provider, that we need you to help us in order to maintain that client, and not only in their recovery, but on their methadone. Because obviously if they relapse, these are the other things that can happen to their medical and mental state as well. So that was some of the other things that we worked on to do the outreach to the family, that there's no crime being a person in recovery and in the OUD. So I'm going to move on to the future of methadone maintenance. For me personally, I really thought that telehealth and telemedicine should be a great tool as far as counseling for people who have OUD. I don't really see the particular hang up about it, but again, it's all about educating the provider, because obviously some other medical providers can actually write the scripts for Suboxone. We had to sort of coach the medical director that telehealth is in the best interest of our clients that we serve. Some of our clients live a great distance. They were using transportation from the insurance underwriter to get to the clinic before the pandemic. During the pandemic, there were issues. We should not punish our client for not being able to come in. There are other underlying issues. There are some things, yes, you cannot do legally over the phone, but we have certain exceptions, and we just think it would be better for all parties involved. So that's one of the things we were able to do with that. As far as the counseling is concerned, remember, we were in a pandemic. Some of our clients, again, as far as the outreach, was kind of hard to get to. So I would tell, and I'm not a counselor, I'm a nurse, even though nurses wear many hats. But I would tell some of the counselors, no, I'm not a counselor. No, you're not a nurse. But at the end of the day, we serve a client. Your client is technically missing, whether it's 1 day or 2 days. Why are they missing? What can we do with the outreach? How can we use this telehealth to reach out to them? when you reach out to your client, can we get consent to speak to that family member or that friend just to say, where are you and how are you doing? You do not want to find out by calling around to the ME that your client has died from COVID or any other medical condition associated to it. You do not want to find out on the TV or the news that your client had a psychiatric break and they committed suicide. So we have to do our due diligence as far as how can we do the outreach, and then what is the best way that you as a counselor can utilize telehealth in order to have a session with your client to get at least meet one or a few of the goals that you set forth with your client together. So that was some of the things that we worked with the client, the counselors rather, as far as, no, when you pick up the phone and call and you didn't get an answer, all right, I left a voicemail. Okay, do it again. Can you send a telegram? Can you send a telegram to the mama just to say, hi, it's so-and-so? You don't have to explain why or who it is, but tell them, can they call me back? Is there another client that you know that's a good friend with that client? Can you we can work around this. This is of the utmost. Unfortunately, we have lost some of our patients at the center due to COVID. And they had no other family members. So some of the other clients in the program was like family. So I said, you need to do your due diligence. If you need help, that's what nursing staff is here for. We need to reach out to them and let them know. If they can't reach out to you with a counselor, they can call here at the nurses station. We have to do our due diligence to be in contact with our patients in order to best serve them. So that's why I felt like telehealth with MOUDs will be a great tool. So again, I'll reiterate, in the post-COVID future, I do believe hybrid telehealth and in-person counseling models can improve treatment outcomes for people with MOUDs. So that's something that we worked on at the clinic, sort of had to change the mindset. Like, you can't always do everything in person. I said, we don't even go food shopping in person anymore. So I know certain things we have to do face to face, but we have to be more viable with the times. And see, there are some of my references right there. So,
Irene, thank you
yes,
very much.
ma'am.
That was a great presentation. There are some questions.
Yeah, I saw some flashing up there. I thought maybe was something wrong with my TV.
No, there's some questions.
No, I thought there was something wrong with the laptop. Like, really? Not now.
So what is the average length of time your patients are on methadone maintenance?
That's a good question because I would say the average time is between 5 to 10 years. Unfortunately, we have some people that have been there. What did the one patient tell me? I was here before, I was doing methadone before you were born. And I say, yeah, well, I was born in 66. So that's saying something. So somebody lying to me about something. If you're trying to tell me you've been on methadone for 20 years, that's understandable. Yes, we do have some clients that have been on for 20 years. Yes, we have whole families from grandma, mama, and the children in treatment. And then there are some clients who come in, I don't want to be on this anymore. I've been on it for 2 years or maybe 3 years. And I want to start stepping down and coming off of this methadone. So it just depends. Obviously, I will say the average age is between 45 and 55, but we have clients in their 70s. And our youngest client is 20, 25, 26. So it runs the gamut, but I do notice a particular mindset between the old timers, and they call themselves the old timers, and the young bucks. So the young bucks just have a more positive mentality of, I'm not going to be in this long. And then there's some of the old timers who just have come complacent, like I've been on it for so long, I don't know if I can come off. So obviously the objectivity there is how can we get them to at least have a different mindset? Because you can't change somebody's mind overnight, but how can we work through this impasse? And if sometimes we do it by our highest dose at one time, 210 milligrams.
Is that your highest dose,
That was
210?
the high, 210.
Okay, because the question was, what is the average dose?
The average dose is about between 60 to 100 milligrams.
Okay.
I said in the middle, it would be 80. The highest I have seen, not in this clinic, but in the other clinic, was 260. And that was with the tablets.
Okay, because one of the other attendees, someone said the highest is they've worked with is 270 and the lowest is 5, and others said the highest was 285 and the lowest is 3 milligrams.
Well, our lowest in the clinic, because it's liquid, and yes,
You can do
is 1 milligram.
Yeah, you can do 1 or 2.
Yeah, so it looks like a, real quick in the, you have to hold it up to the light, like make sure I got that drop in the cup or the take-home bottle. I questioned the 1 milligram because the person was also 28-day take-home. So technically 27. They come in the clinic, they do the drink, and then they have the 27 take-home bottles. So I said, obviously the person is either high functional and they have other things going on, but is that some type of cognitive behavioral type of therapy thing that needs to be going on? So, I mean, the doctor told me, well, I'm gonna leave them at 1. And I was like, okay, but what are we really doing here? I said, I think we spend more money on the cup than the spit, but that's just me. And obviously, the person that was on 210 milligrams, we eventually dropped that person down because I'm an identified gender, because it was a female, and then she was pregnant in therapy. So we had to have the consent signed between, the medical director and the OB and the pediatrician, because then we had to work with all, the team to keep her medicated during the pregnancy. And then it was mentioned, like, how is she going to start stepping down because she has a child to take care of. So that particular person is no longer on 210 milligrams, but that's the highest I've seen at that clinic, and 260 at the other clinic with the tablets. But yeah,
Okay.
it runs the gamut between 1 milligram and up, if it's liquid, or the 5 milligram tablets and the biscuit.
Right. So the next question I had was, can you explain the process of identifying a patient? Was it just a code word or a picture ID?
Well, universally, most programs, we take the picture, we make our own ID. So they usually have a state identifiable ID number, meaning I'm here in Queens, I moved to Buffalo, I transfer from my program here up to Buffalo. It's called Lighthouse as far as the dosing, and entering a new person into the system and therefore generating their ID number. So that ID number follows you all through the state and beyond, because if I go, I can guest dose. So most people don't know, I know people here on this webinar, most people don't know if you have a family member that's on methadone and they decide they won't go to Disney World, and for whatever reason, the medical director feels it's not a good idea to give them take-home bottles to take with them to Disney, but we can transfer you down to a clinic in that particular area to guest dose. All we have to do is have your counselor reach out, start the temporary transfer process. We will send them a information by fax with your ID number and actual send them a copy of your ID card. And the client knows when they go to that clinic, they have to pay as a guest dose, particularly if it's out of state. Because I tell them this is not, that's Florida, this is not New York. You're gonna pay for every time you go in there to drink. So you need to ask them, is it $20, $25, $50, whatever? And you have to show them your program ID card, which has your picture on it, your full name, the ID number that you received from Lighthouse. If they ask you for additional picture ID, you have to provide it. You have to pay for your drink. And you have to pay for it on the spot. There is no drink now and pay at the end of the week. So yeah, we give them ID cards. And on the back of the ID card, like on the back of your credit card, we have the customer service number. In the event you lose a business card, you can drop it in the mail. Same premise. On the back of the card, it has our full address of the clinic, and it has our regular clinic hours operational number, and it has our emergency on-call 24-hour number, which usually the clients use in the event they go into the emergency room for whatever reason, and they have to be dosed. They have to verify the LDM, the last dose of methadone given. So we do get calls from emergency rooms, or if the client gets guest dose or they go to another clinic, they want to transfer out. Or during COVID, when we were doing the medical deliveries of the methadone, my client, if he lived in, because we didn't do it to Staten Island, we did every borough but Staten Island. I don't know what that was about, but that was a city thing. If my client went to another program in the Bronx, that program could call us to ask what was the last time the patient was dosed and with what. So the same thing with the emergency room. We have your client here, he's a patient, we need to verify the last dose of methadone. The only thing we have with that gets kind of tricky if a client missed doses. So in our clinic, because we have technically 3 separate clinics in this one particular organization. I'm in the early one. We open up at 6, we close at 2. The late one starts at 9:45, they close at 6. And then we have an inpatient detox with a methadone dispensary. And then we have the pregnant women and infant and children program. Our unit 1, which is the early clinic, if you miss 2 days, you have to be cleared by medical. The clinic down the block is 3 days. And whatever days you miss, minus 10. So if you miss 5 days, 5 times 10 is 50. If you're on 150 milligrams, you go down to 100. And every 2 days, we increase you by 10 till you get back to 150. So if you miss 5 days and you end up in the emergency room, and we've had some of our clients say, I'm on 150 milligrams. When that provider calls, we'll say, yes, they were, but since they missed 5 days, if they were to come back in the clinic today, they will be started at 100. And we will have the medical director tell that particular provider, this is how you are going to dose the client while they're in your care. And then you release them back to us. We in turn turn around and call the hospital to ask, when was the last time you gave them the methadone and what dose did you give them? Because now they need to be evaluated here at the clinic and we need to know what to do. So that's how we do with the missed doses. If they miss in our clinic 5 days or more, then it's technically almost like they're doing a whole intake process all over again. Now, for somebody that was on 30 milligrams when they walked out and they missed 7 days, and they get upset as to why I got to start at 30. When you left, you were on 30. We don't know what you've been doing while you were out there in the streets. And quite frankly, you would look rather well, but I can tell the whole story by the time you finish giving me these good samples. And at the end of the day, we don't want you to drop dead. It's your choice. Yes, we've had ODs in the clinic during clinic hours. So it's something to be mindful of, that we remind the clients, you can't tell you what to do, but we would advise you that you cannot keep missing days. Number one, it throws off your therapeutic levels of the methadone in your system. And it's a big hurdle as far as you and your recovery process. So whatever particular root causes, you need to discuss that with your counselor. If you're having some other type of issues that might warrant a referral to other mental health services, we are more than happy to give you that referral to a licensed mental health provider. But at the end of the day, you are hurting yourself with these missed doses. So yes, that's what our ID. If they don't have program ID, they have to show us a government ID, driver's license, they have a passport, their benefit card has their picture on it. If they're in the military, some type of, it has to, and it has to be current. Because some of the clients, when I started there, they might have been there for 20 years. They had that picture on when they were like 30. I said, yeah, but you at 55, you don't look like that. So how do I know that's really you? So guess what we're not doing today until you show me a current ID. And while we're at it, you're going to take a new ID to reflect what you look like. Not only just to drink, but in the event you get missing, God forbid, the cops come and they ask, are we trying to help find you? We need to know what you look like. And right about now, you gray hair. Back then, you had red hair. I mean, that's just common sense, but
Here's another
Yeah.
question. Do they have Narcan sent home to their families? Are the patients provided Narcan?
Yes.
Family members? Okay, yeah.
Well, here, in the city, they giving it out like candy. We have some providers that, okay, there's a program up in the Bronx, East Tremont, Arthur Avenue. On the corner is McDonald's. On the side of McDonald's, there's a provider that does Narcan trainings for free on the side of McDonald's. Literally, right there on the street. We just give it out like candy. You could go to any pharmacy and get it.
Okay.
So we give, especially during the pandemic, and we were doing the home deliveries, we will put a pack in there.
Oh, that was great. Right. Okay, any other questions for Irene? I do not see any more questions. And we have 7 minutes left. So if anybody has any questions. Okay, well, Irene, I want to thank you very much for this informative presentation. It was very educational to me, what was going on, to learn about COVID and methadone during the time, the take homes and all the bottles that were given. I do want to remind people that we will be meeting again on October 19th. It'll be Mindfulness by Dr. Tracy Hicks. I encourage you to attend and also share the information with your colleagues and encourage them to join. Have a great night. Have a good weekend.
All right. Thank you, everybody.
Thank you all.
Bye-bye.
Bye-bye.